today was intended to be kind of to go over like how to treat some of the joints and stuff, and we can definitely dive into that and try to help you get confident in some of that stuff. But any questions or anything before we get going?
I do actually have, which hang on, I'm just annoying myself with. I would love to. I can't work out which camera I'm using. Hang on. There we go. This is sort of just a businessy question. I'm just interested, like between you and your wife, how do you guys co-treat clients, or do you both do the same things?
Yeah.
Or if some, yeah.
So for this type of condition, what we do is most of the time people enter the door and they're looking for me for this. And I will kind of be able to figure out if they need to see her from a vestibular. She would kind of be more like, all right, let's clear out the canals. Let's see if you need any like convergence, divergence training, kind of go down that vestibular route. So quite simply, like that's kind of how it does. And sometimes, my clues for that would be a lot of times by the time somebody gets to my office, many times they've already gone through some sort of vestibular therapy. But like, let's say they've only done chiropractic, or they just are self-diagnosing themselves, and they haven't done that, and I'm like getting some clues that there could be, based off of their history, like maybe there's something going on there. Let's just rule it out. So that's typically what we would do. And sometimes we'll go into her office, depends on what she finds. The goal is to maybe enter back my office. So does that answer your question from that
Sort
end?
of. What about if they come to her with a vestibular condition? Does she then try and treat the neck, or does she send them to you and then they go back? I guess where I'm coming from is obviously I don't have a team. There's three of us, and we're all sort of neurological vestibular therapists. And I guess from a business point of view, and we always send our necks out, and with varied success.
Okay. So to answer your question on that, she knows and does all the stuff that I do. So typically if it goes in her office, she's going to do this type of stuff too. And I think that's ultimately my goal, to help you all to have that continuity of care where, they're not like just seeing somebody, you're like putting all your trust, you don't really know what's happening, it could make them worse, and you're putting out the fire, or vice versa. But I think like this kind of stuff, and we can talk more like how we incorporate it, but it could be from a business standpoint, it could be great. Obviously, I think clinically it'll be great too. But I think it'll take, you kind of got to put a different hat on though. It'll definitely interrupt your current flow. And I think that's where like some of these techniques I've sort of just, without the assessment aside, like sometimes you can just strategize with just the techniques that we do. That way you can say, all right, let me try X, Y, and Z for 10 minutes or whatever. And you kind of try to add it into your flow wherever you feel like might be best based off of your exam. I think for you and your staff, like the more you guys can just jump in and try it on each other and just try it on people, you just got to get into that flow. If not, it's just like one of these machines that you have in the corner that no one uses after a while.
Yeah.
What do you all Do your other therapists do any like exercise from a orthopedic standpoint, or manual therapy at all?
We don't do manual therapy. We very much do. We do a little bit of exercise therapy, probably kind of a little bit of a shotgun approach rather than, like we probably do. We would always do retraction. Sometimes we'll do rotation stuff. From an exercise standpoint, we always do sensory motor retraining. So like we've been doing joint position error lasers and stuff for a long time. So this is trying to pull it all together. And
yeah. So like, I would say, because you see them for like 30 minutes, give or take?
An hour.
Oh, so you have a whole hour. Okay.
Yeah, we can have a whole hour with most people. Some people we're seeing for 30 minutes, but that's because we can squeeze in. But some of those are the BPPV ones or the a neuritis.
Yeah. So if you could break down, just generally speaking, 60 minutes, what's kind of your flow right now?
For we said like a concussion, we'd be doing, we'd probably get them on the bike to do some priming. And then depending on where I probably start with visual stuff.
Okay.
And then maybe some vestibular, and then I'd probably interact with some balance stuff, and then I'd probably do neck stuff at the end. Although I am changing my own flow, been doing a little bit of cardio when we're talking to them. Then I did a little bit of eye stuff. If we're doing seated remapping, then I'm doing a little bit of neck, then I'm doing some vestibular and sort of,
Okay. What's making you change your flow now? Is that just switching it up or anything? You're seeing anything different?
Because of this, for me, I'm doing a little bit more manual. So I'm thinking my clinical reasoning is if I do a little bit of manual before we do head movements, vestibular, if the neck's moving better, I'm going to get a better outcome with those exercises.
Yeah. All right. That's kind of my thought too. And that's sort of like our flow. But depends on, like you said, the individual. And I think you gotta, for you all, you kind of have to balance giving the good stuff, like, you doing that and not allowing them to almost like get into like, well, I don't want to do anything state. And that's kind of like, that's a little bit of sort of your priming. I call it priming too. And just what we've talked about with the muscle spindles and changing that input. You're priming that system to then say exercise, maybe strengthening, which we'll get into more next week, like getting things to kick in where they go, or like you said, a sensor motor, putting it all together. Maybe their range of motion improves, so you get better outcomes. And so we would incorporate the flow a little bit from the beginning. I think what you might run up into is you may run into like someone being like, oh, that felt a lot better, and then they say they're doing some more exercise. They may say, hey, well, I'm kind of feeling that like kind of get tight down here or something, and then you kind of got to say, all right, well, do you abort the mission of what you're doing and treat that, or how, you know what I mean? Like sometimes they can be really nitpicky there. So I think you have to sort of be the quarterback from the get-go of how you want it to flow, if that makes sense, just quite simply. Because, some people just want to come in, and that's not your office. It's, some people just want to come in and have something, and we know, like here's our treatment plan. We're at, for you all, it's not, the nice thing about something like this that I always did, it's like, hey, I've taken a continuing education course. I'm going to try a couple more techniques on you before we do the exercise. That could be, and hey, tell me if you think if it works better. Maybe some of your clients have been coming for a while, and kind of get that feedback and see how that goes.
Yeah.
But I think I think you just have to sort of sit down and figure out where you want to incorporate it. Now, I will say, sometimes it depends on that. If you have someone who is just crazy ramped up, and these techniques are kind of good for that, even if it wasn't like vestibular. If it's like, say you're trying to calm someone's vagus nerve down, if that makes sense. Like a lot of these techniques are the same pathway as it. I just don't call it that per se. But so what I'm getting to is these could be utilized in a flare. You know what I mean? And I'm not talking about like straight BBV. It could be someone overdid it. Like, say had a concussion, they overdid it on social media, or didn't eat right, or and you're like trying to figure out, talking to them, but this could be like some strategies. That's a little bit how we incorporate it too. It's kind of, I'm doing some things and I'm like talking to them at the same time, like getting more information, like subjective stuff. Yeah. So, well, what have you done so far in terms of practicing on some current people?
I've definitely been doing the soft tissue stuff. That's all I've got to. I've looked at the joint stuff and then went, oh, I'm going to have to practice that before I do that on client.
Yeah. What's the outcomes? What are you seeing? What are they seeing? Any connections or anything?
I definitely think, with a couple of them longer term ones, a guy we were talking about last week, he came back in and he said he felt quite good. So we did some more. He's still really tight up through his left side. So we did a couple more of those trigger points and then some release. And he felt, I could see his movement was a bit better. It's interesting. He was dizzier when we started doing like times one left to right, which he hadn't been. So I wonder if we've got some more range that we're now starting to access his vestibular system more. And then I've been doing like governing vessel, is it 12 or 20?
20, yeah.
20. Yeah, that as well. One patient didn't like, she was a bit strong. What didn't she like? She didn't like the suboccipital release. So that felt a little bit better. I feel like we're getting some more stuff going with those for people.
Okay. Well, yeah, that's interesting that, like, if they're accessing, like, another layer, especially rotation for the most part, or just kind of entering into another range or dimension of training, that's good. I mean, I know like a lot of the stuff is short amplitude, right? Short amplitude. Yeah. But I think to maybe kick in that cervical ocular reflex, kind of just sort of getting some of the range, and I find that that kind of can be a progression for them, almost just like we progress speed and you progress time with some of that stuff. You may be able to progress range. I don't have like a particular range we look for. I try to. This is one of my big things, to be honest. If say you're doing some VOR or VR2, I like for it to be like, if you say check that neck at 30 to 45 degrees, I like for that to be almost